Good morning, everyone. It's a real pleasure to be here. Thank you so much, and thank you for this opportunity. My name is Martina. I'm a second-year infectious diseases resident at the, at the hospital in Aveiro, which is in Portugal. It's a coastline city in the northern central region of Portugal. Really recommend for good food and surfing. But today, as mentioned, we're going to talk about HPV prevention strategies among women living with HIV, gaps and opportunities in the women that are followed by our centre. Okay, so I have no conflicts of interest to disclose. We're going to have a look at the literature first of all, and then we'll dive into the actual study that we conducted. As I'm sure we're all aware, the human papillomavirus is the most common sexually transmitted infection worldwide and is associated with anogenital lesions and various types of cancer, including cervical cancer, which is the fourth most frequently diagnosed type of cancer. It is the fourth most leading cause of cancer-related deaths in women worldwide, and over 90% of cases are associated with HPV infection. The actual prevalence of HPV infection among women living with HIV is up to 6 times higher than women in the general population. The immunosuppressive state that is associated with HIV infection does facilitate the persistence of HPV infection, and studies have shown that it is this persistence which favors carcinogenesis in oncogenic HPV genotypes. With regard to the possible risk factors associated and described in the literature for HPV infection and HPV-associated disease, a low CD4 T cell count, detectable viral load, and shorter duration of antiretroviral therapy have all been described in the literature. There has also been identified an inverse relationship between CD4 T cell count and the risk of high-grade lesions and, down the line, evolving to cancer. Other than the short duration of ART, another factor that has been described is also that it has to be it's effective ART that has been identified to decrease incidence, progression of HPV infections to then cancer. However, in a woman living with HIV who is virally suppressed, long time on ART, and has a good CD4 T cell count, this population still presents a higher risk. So there are some additional factors other than the immune suppression described that may be at play here that are still not well understood. 1.5 to 3 times higher prevalence of pre-malignant lesions globally in women living with HIV, and there is also a 1.5 to 6 times higher increased incidence of cervical cancer among this population. So we can tell this is a pretty important topic in our women living with HIV. And the most prevalent HPV genotypes among women living with HIV are those covered by the nonavalent vaccine. Studies have shown also that people living with HIV, their cytology results from anal lesions and cervical lesions have shown a higher variability and generally different genotypes compared with the general population. So the inclusion of HPV vaccination in the routine clinical management of women living with HIV is fundamental in both primary and secondary prevention, eventually in this high-risk disease group, high-risk group. So having now a look at our actual study, it was a retrospective analysis of clinical data, so from medical charts, of the women living with HIV that are followed at our immunodeficiency clinic at the hospital in Aveiro. Our objectives were to characterize women living with HIV with regards to their clinical characterization and their adherence to both a cervical cancer screening and HPV vaccination. So, our centre follows a total of 983 patients, or people living with HIV, 20% of whom are women, and the vast majority have a type 1 HIV infection. The median age was 52 years of age, and the median time since diagnosis was 13 years. The vast majority acquired HIV infection via sexual transmission. In the most recent consultation, 96% presented an undetectable viral load, and the median CD4 T cell count was 667 cells per microliter. As you can imagine, the vast majority were Portuguese. We did have significant groups from other countries that have a cultural and political connection to Portugal, so 9% from Brazil, 8% from Angola, and some other countries, African countries as well. And we also did have a small proportion of women from Eastern Europe, specifically Ukraine. The median time on ART was 11 years, and the majority, at least the larger group, was under dolutegravir 3TC. Then 16.5% were with Biktarvy, tenofovir, and FTC, and then roughly around 22% were under other regimens, with 17% of women having a prior history of opportunistic infections. When it comes down to the actual cervical screening, 84% of the women living with HIV followed by our institution underwent recent screening. Roughly half were in line with the 2024 IACS guidelines, which at the time were the most recent when this study was done, which generally described that women over the age of 21 should do annual cytology testing, or if above the age of 30, should do a co-test with cytology and HPV testing. If negative during those first 3 years, they can then pass that on to doing every 3 years instead of annually. Within the women that did cervical cancer screening, 59% were in a primary care setting, with roughly about half of those women in line with the IACS 2024 guidelines. A third were screened at our institution with the gynecology department, and a higher proportion of these women were in line with the IACS 2024 guidelines, and this difference was statistically significant. A smaller percentage did their screening in private institutions with 100% adherence to the IACS 2024 guidelines, and a very tiny 1% was screened either in other hospitals, public hospitals, or in prisonal institutions, which does also remind us that these women also require and should be followed up with care and preventative or primary prevention. When it comes down to the results, 18% of women had a positive HPV results. The large majority were non-16, 18 genotypes, followed by 18 and then 16. 32 women had abnormal cytology results. So now we've shifted to the cytology end of things. And the mean CD4 T cell count was lower, and this was a statistically significant difference when compared with the group that had a normal cytology result. According to medical charts, which, as we all know, can sometimes be incomplete, but of the information that we did have, 2 women living with HIV were identified as having condylomas, and there was 1 case of cervical cancer. I would like to also add that there was no statistically significant association between cytological abnormalities and age or ART duration. The vaccination uptake was fairly low in this population, with 11.7%. Most women who did undertake vaccination had the monovalent vaccine, followed by the bivalent vaccine and the quadvalent vaccine. All of the women did 3 doses, and the majority were vaccinated after diagnosis. What I can tell you also is that the women that were vaccinated the majority that were vaccinated either had a history of abnormal cytology results or positive HPV testing, and then were recommended by their gynecologist to get vaccinated. The other women were eligible, according to the Portuguese national vaccination program, to get vaccinated, and therefore their vaccines were subsidized. And then a smaller proportion of women were the odd women that didn't have necessarily any reason other than being a high-risk group, and they got vaccinated all the same, which is fantastic. To conclude, and to give an overview of what we found in our analysis of the data from our institution, there was a high uptake of cervical screening, which is fantastic. Approximately half are in line with the most recent guidelines, and this is possibly, again, due to the fact that a lot of women may have difficulty accessing care, particularly migrant populations, knowing where to go, how to go. A larger proportion of women were screened in primary care facilities, and these doctors do follow generally the national guidelines, which are more permissive than the ACTS 2024 guidelines. Our department used to have a protocol with the gynecology department, which unfortunately no longer exists due to some professionals leaving the hospital, and generally resources just were not able to provide this referencing. The low HPV vaccination coverage is not ideal. There is a significant gap in primary prevention strategies. I do believe that the main issue with this is the economic burden. A lot of women would not have been eligible for the government subsidized vaccine, and the cost of each vaccination dose is roughly around 130 euros in Portugal, which is significant for our population. The increased risk associated with HPV and HIV co-infection is there, so we should really focus on reinforcing primary prevention measures, coupling that with an effective surveillance and thereby maximizing early detection and intervention of premalignant lesions. That way we can identify these women sooner, treat, reduce complications, and thereby increasing quality of life and survival down the line, which is really, really important. Thank you very much for your time.